Right. Hello, everybody. Welcome to Regional Pharmacy Grand Rounds. Can everybody hear me okay? Okay. I will take that as a sign as yes. So I will proceed. My name is Heather Naylor. I'm the Pharmacy Research and Education Coordinator for Horizon, and I'm also your facilitator for today. So welcome, everybody. It looks like we've got quite a few sites signed on, so I'll get started. A special welcome to our fourth-year pharmacy students who have started this week at our sites across Horizon. So today's journal club is going to be a little bit different than other ones. We're going to be talking about motivational interviewing. I'm not sure how much exposure people have had to it or if they've heard of it, but we will go through it today and give you an overview. So we'll go through what the spirit of motivational interviewing, or MI, is, and some of the principles and key skills. Just a note that this is quite a big topic, and I'm not meant to teach you everything you need to know in 30 minutes today, but just give you an overview of what it is. If it's something that people are interested in, we can certainly have more in-depth education sessions on this in the future, but most people who are trained in MI go through a 3 or 4 day course minimum, so today's just an overview. We'll go through some key findings from the study that was circulated, and then I'll give you a few tips on how you can introduce some practices of MI into your daily practice. So I just want you guys to think for a moment about a common scenario that would happen. So if you were working in a pharmacy and one of your patients, Mrs. M, comes in, she's 67 with diabetes and hypertension, it's pretty standard in the Maritimes. Today she's here with a new prescription for perindopril, but she tells you she doesn't really think she wants to take it. She's just on so many pills already, so what's the point? So I want you to think about your current practice. What would you be thinking about? What's going through your head? How you would approach this patient? So take a moment to reflect. Keep that in mind, because we'll come back to this after the journal club and see if you might have changed your approach. So we know that non-adherence is really common in practice, unfortunately. In some disease states, it's up to 50 to 80% of patients. We do have a lot of trials that have looked at different interventions to improve medication adherence, but unfortunately, a lot of them haven't been found to be effective. So that leaves us in a hard place if we know it's a problem, but how do we fix it? When patients are labeled as non-adherent or non-compliant, from what I've observed in practice, and maybe you've seen this too, we're very quick to judge and say, oh, this is a problem patient, they're difficult, they're not taking their meds. We might get annoyed with them and not understand why they can't just do what they're told. But I encourage you to, instead of labeling the patient or thinking them as non-adherent, seeking to understand why that is. So we just started the new year, 2020, ignore the 2019 there, but we know that New Year's often comes with people making resolutions, and oftentimes it's health behavior changes. So can you think of a time when you yourself wanted to make a change in your life, and how did that go? So I've said multiple times I want to stop eating close to bedtime. I know it gives me heartburn and I don't feel good the next morning, but then my husband breaks up the Doritos on the couch. He's like, well, those look really good, and then I'm off the bandwagon. I'm sure all of us have been in that situation. So behavior change is really hard. So why don't people comply with health behavior change? There's lots of different reasons. It's often multifactorial. Sometimes their values don't support the change. Maybe they don't think it's important they get their blood pressure down even though their doctor tells them they need to. They don't think they can, so they're not confident they can change. Maybe they haven't worked through ambivalence about it. And when I say ambivalence, it's feeling two ways about one thing. So maybe, I think it would be good to stop eating Doritos close to bedtime, but at the same time I really like them, and weighing the pros and cons to that behavior change. They may not be ready yet. If you've heard of the theoretical model of change, so people move through different stages. They might be contemplating change but aren't quite ready to take that action yet. Maybe they don't have a good plan in place for how they could change, and a lot of people just don't have the adequate social support they need to. So our traditional approach to some of these patients and changing behaviors, especially in healthcare, it has in the past been very didactic, and the health professional is the person that knows it all, and our job is to give advice and do most of the talking. So if you think of traditional pharmacy models, we're taught that a patient starts a new medication, we have to cover this, this, and this in the counsel and make sure the patient is told all of it. So we're providing the agenda and deciding how that discussion is going to go. But with patient-centered care and motivational interviewing becoming more mainstream these days, it's switching to a more patient-centered approach to care. So bringing in things like actively listening to the patient and partnering with them, figuring out what their goals are, helping to empower the patient to make change and address their concerns. So they're also helping to dictate the course of how this discussion is going instead of you coming in as the expert and telling them what they need to do. So motivational interviewing, the definition in the literature is a directive client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. So you're helping them work through how they feel about change, what the good would be, what the bad would be, what are some barriers to change, and helping them work through that. It was initially started in the addictions area back in the early 90s, but since then there's been more studies in mainstream healthcare, even in short encounters and office visits, and it's been found to be effective. So if you've done any MI training or heard of it, you may have heard of the spirit of MI. So when they say the spirit, it's like a way of being, I guess, or the soul of it. So CAPE is one acronym that's used, also known as PACE. So just being very compassionate with the patient and their struggles and where they are, and accepting them where they are. So not trying to change them. If somebody says, I'm not ready to quit smoking, accept that's where they are and help them work through how they feel about it and what would be the good of changing, what might be the bad of staying the same. So you're really partnering with the patient and evoking them to talk about change, because the more you talk about change, the more likely you are to actually change. And remembering that the client is an expert in his or her own life, where you might be the expert in the healthcare side of things. Their life and their values really affect behavior change, and they are the expert in that. So the principles of MI are often referred to as rule. So resist telling them what to do, which is also known as the righting reflex. So we naturally, if the patient says something incorrectly, or we think that they need to change because it's good for them, we'll switch into healthcare provider mode and tell them what they should do. If somebody's ever told you what you should do and you don't agree with them, oftentimes we get very resistant to change and we'll dig our heels in. So keeping that in mind. U is for understanding the patient's motivation, and this is different for everyone. Listening with empathy and empowering your client, making them believe that change is possible and helping to support them on their journey. The key skills of MI are often referred to as ORs, so open-ended questions. It's pretty self-explanatory, questions that you can't answer with a yes or a no that take more explaining. Affirmations is really promoting optimism and acknowledging the client's efforts. So simple things like, that must have been very hard for you, or a lot of people feel the same way you do about this. Reflections is reflecting back, kind of like a mirror to the patient, so reflecting back what they're saying. So it could be as simple as saying exactly what they just said. Patient says, I feel sad. You reflect back to them, you're feeling sad. Or you could try and summarize what you think is going on, but maybe they haven't verbalized. So if they seem really anxious, reflecting that back to them. And then summaries are at the end of the session, summarizing what was said in that discussion and highlighting key points and an action plan for going forward. So why use motivational interviewing? It has actually been shown in studies to improve medication adherence, which we deal with a lot in our day-to-day work, can decrease hospitalizations and has been shown to improve certain health behaviors like exercise and reducing salt intake. So even in short encounters, pharmacists can use motivational interviewing to promote adherence to medications and other health-related recommendations. That brings us to our study. So this was out of the States, looking at motivational interviewing by pharmacy students to improve medication adherence. So the purpose of the study was to examine the effect of a motivational interviewing-based telephone intervention conducted by pharmacy students in improving adherence to ACEs or ARBs among Medicare Advantage plan patients with diabetes and hypertension. So a Medicare Advantage it's a Medicare plan that's offered by a private institution within the United States. So it took place in Texas. It was through the University of Houston College of Pharmacy. So a single center, it took place at the Medicare office, and they used fourth-year pharmacy students that were doing their 6-week advanced pharmacy practice rotations at the Medicare site. So they included patients, they were able to find them through their their statewide database. So they looked for people who had both a diagnosis of diabetes and hypertension, which would have been coded using their system. So they could flag those patients. They had to have been prescribed an ACE or an ARB in June of 2014 and have at least 6 months of refill data that they could use. And they had to meet the definition of non-adherent that was based on this PDC calculation that I'll go into in a bit. So that had to be less than 0.8 or 80%. They were excluded if they disenrolled from the drug plan, if they had dementia, or if they had a documented contraindication to the ACE or the ARB. So they in total had 743 patients. They were just under 70 years old, and 56% were female. So the pharmacy students did 6 monthly motivational interviewing calls. So an initial call to the patient and then 5 follow-up calls after that. They were supervised by a pharmacist or a resident that were trained in motivational interviewing. And the control was no intervention, so they received no phone calls. Their primary outcome was to evaluate medication adherence between groups over the 6-month period. And then for a secondary objective, they wanted to look at some predetermined baseline characteristics to see if those had an effect on their adherence. So all of the students that did take part in the study did have some training on motivational interviewing. So it was a 3-day course that they did before rotation started. The first 2 days were your traditional lecture-based discussions, watching role-playing. And then on day 3, they each did 3 simulated phone calls with standardized patients. And those calls were recorded and reviewed by the facilitator, and then students were given feedback on their performance and also scored on their skills. So they used a 7-point scale to score them, with 7 being excellent or always, and 1 being poor or never. And most of the students fell on a 3 to 4. So about average. You wouldn't expect them to be getting 7s after a 3-day training program. So when they looked at medication adherence, they used this proportion of days covered calculations. It's becoming more of the gold standard for adherence studies, where people are switching to this one because it is able to account for early refills from patients. So what they do is look at when you filled your prescription and calculate out the number of days covered or the number of days you would have had medication for, and divide it by the number of days in the period to give you a percentage. So 80% is acceptable in most disease states for adherence, but there's other areas like HIV or transplant where you might want to see that number higher to make sure that you're adequately treated. If anybody's interested, there's a YouTube link there for a video. I won't go into further detail today. This one, you may have seen the medication possession ratio used in adherence studies as well, but that one is starting to fall out of favor because it tends to overestimate true adherence because it doesn't really account for early refills, where the PDC does. So as far as results, there was around 50,000 people who had diabetes and hypertension within this drug plan. So then they weeded out the people who had filled the ACE or the ARB, patients who had 180 days or more of data that they could measure, refill history data. And then they looked for people with the PDC less than 0.8 or 80%, which would mark them as non-adherent. So then they divided them out into a control group and intervention. The controls just didn't receive any calls, so they got their prescription filled and went on their way as part of standard practice. The intervention group, they randomly chose people from a list to call until they reached 250 calls. But you'll notice that they only had a 14.6% success rate for their phone calls. So they had to call a lot of people before they actually got an answer. So they listed reasons as people just not answering the phone, not returning messages, wrong phone number on file in a lot of cases. But they eventually got their 250. They lost a lot to follow-up, so after the initial call, by the 5th follow-up call, only 50% of people were still answering the phone. You'll notice, so the numbers here, the 500 and 250, add up to 750, but there were 7 patients they excluded later on for missing data, so they ended up with 743 people. So there were 2 pharmacy students each week making the calls. Their mean number of successful calls per week were 18 to 20. So if you do the math, if they had a 14.6% success rate, it's about 140 calls per week and only 18 to 20 successful ones. The mean length of the initial call was 12 to 13 minutes, and follow-up calls took about 5 to 7 minutes. So for the baseline characteristics, you will notice that there are lots of characteristics that are not balanced. And the explanation for this is that when they originally randomized people to the treatment groups, they were balanced, but because so many people didn't answer the phone, then it started to skew the baseline characteristics. So they ended up with an older population in the intervention group, a proportionately larger amount of females, and higher rates of heart failure and stroke. Whether or not that impacts results, it's hard to say. Also interesting was that 60% of patients were receiving a low-income subsidy. So these, for the most part, the majority were lower-income patients. And 33% had had a previous hospital admission within 6 months prior to the study. The mean number of medications was 12 in the intervention group and 10 in the control. For their primary outcome, they did find a statistically significant difference in medication adherence. When you look at the PDC calculation, the intervention group went from 0.63 to 0.66, so that's a 3% difference in adherence rates. Whether or not clinically you consider that successful, statistically it was. The control group actually got worse, so they went from 0.6 to 0.56. It's, like I said, medication adherence is very difficult to treat, and there's been a lot of negative studies, so in that light I think it's good that they did find a positive effect, but it was very small. Although I do wonder where a lot of these were cold calls to people they didn't know. Perhaps if it was in a clinic setting where you knew the patient and invited them during a visit to take part in this service, maybe you'd have more buy-in. For secondary outcomes, they did both a linear regression and logistic regression. So the linear found positive associations for increased adherence with patients who had 2 or more follow-up phone calls. Higher medication adherence before the intervention predicted higher adherence post. And surprisingly, if you were on a higher number of medications at the time of the intervention, you were more adherent. I would have thought that would be the opposite, but that's what they found. And heart failure and depression were associated with worse adherence. The secondary outcomes with the logistic regression was very similar. So 2 or more phone calls. Patients were more likely to become adherent and less likely to stop the ACE or the ARB. Higher adherence also was associated with better adherence post. And like I said, the higher number of medications pre-intervention seemed to be associated with higher adherence after. So the study did have a large sample size, and they did meet the number that they needed to have to meet their adequate power. They did use objective data to look at the refill history, and the intervention could be replicated using pharmacy students in other provinces or states. So I thought it was interesting knowing that in Canada soon, in New Brunswick, we're going to be getting more pharmacy student learners come through as they switch to the PharmD program. So this might be a type of service that perhaps we could use in different areas within Horizon. There were some limitations, as with most studies. So unfortunately, those baseline characteristics did become imbalanced. Whether or not that had an effect on results, it's hard to say. There was a high loss of follow-up, and adherence rates, even though they did improve, they didn't go above 80%, which is considered adherent. So at the end of the study, patients would have still been classified as non-adherent with their medications. So what is still unknown? We don't know if this intervention is sustainable after 6 months, so do adherence rates drop off after that? We don't know if the phone call intervention affects clinical income or clinical outcomes because they just looked at the refill history, so adherence. It was done only in Texas, so whether this population is similar enough to here, will we see similar results? And we don't know if a shorter intervention period, so if they just did 2 to 3 follow-up phone calls, would that produce the same results? So in conclusion, this MI intervention, it did appear to increase or improve medication adherence and stop people from discontinuing the ACE or the ARB, but whether or not we're impressed by a 3% increase in medication adherence, I'm not sure. So I'll pause there to see if anybody has any questions about the study or any comments.
Just curious about the 80% for adherence. Is that a number that comes from literature, or is it an arbitrary number?
Yeah, so the question was where the 80% cutoff comes from, and it does come from the literature. There's no consensus that that's the number you should use, but that's what most people say should be a cutoff for most disease states.
Have there been any studies like this done where the people who are doing the motivational interviewing are interviewing their own patients from their pharmacy? Because I feel like that can make a huge difference. Like someone you know versus a stranger calling you from Medicare.
Yes, yeah. So the question or comment was, do we have any studies with people at their own pharmacy doing this with their patients, and whether that makes a difference? I'm not sure if those studies are out there, but that would be an interesting thing to look at. Because you would think that if the patients knew you and you had that relationship, you might see different results. I'm going to check on Skype and see if we have any questions. Okay. So I will proceed. I'm going to try and keep this to 30 minutes. So we're going to go back to the case, and I have a lot of slides after this, but I put them there more as a reference for you guys to use. And if you're interested in hearing more about any of these, we can try and arrange more education on them. But I can't teach you motivational interviewing in 30 minutes, so this is just some tools that you can have if you'd like more information. So we're going to go back to Mrs. M, who doesn't want to take her perindopril, and keep her in mind and what your current approach is when we go through the next few slides to see if you are doing these things already, and if not, would they be a good fit for your practice. So I put together a motivational interviewing tool belt for people. So these are different things that you can incorporate that are all part of motivational interviewing. Some things like empathy and active listening, I think you'll have a good grasp on what those are, but I do encourage you guys to think about when you're listening, because I always thought I was a good listener, but how many times when you're talking to a patient and they're speaking, are you thinking in the back of your head, okay, what is the problem that's going on? Or what am I going to say next to this patient? If you're doing that, you're not truly actively listening to the patient. You really need to be in the zone, focusing on them and what they're saying, and not thinking about what you're going to say next or finishing their sentences for them. So we'll go through. I want to highlight a couple of these in the time we have left. Open-ended questions, I think, are pretty self-explanatory, and I've given you a slide of questions and how to ask them different ways there if you're interested. For example, if you ask the patient, can you tell me what this medication is for? Perhaps instead asking, tell me what this medication is for, or tell me how you take your medications, making them elaborate more on it instead of saying yes or no. So affirmations, we've gone through, reflection. So eliciting change talk is one of the key pillars of motivational interviewing. And one way you can do this is to ask open-ended questions about patients' desire to change, their ability to change, reasons for it, and the need. So some examples would be, in what ways would it be good for you to take this medication? What would be the good things about it? What would be the bad things if you started to take this medication? And by doing this, you're getting the patient to really reflect on how they feel about the change and what might be some barriers for them to change, what might help them, just to get those gears starting to click, because maybe they haven't given this thought before. And the more someone talks about change, the more likely they are going to actually change. So that's one key thing I want you guys to take away from this today, the more you get patients talking about change and thinking about change, the more likely they are to actually change. So this is a useful tool if you're trying to assess somebody's confidence and readiness for change. So you can ask them how important it is for them to do a certain behavior. How confident are you that you can actually take this medication every day? If I say it's a 5, okay, that's where you are. How can we get you from a 5 to an 8 and get them to think of ways? Notice how I'm not telling them what they need to do, but getting them to think about it and use their experience. So asking versus telling we had touched on in the beginning. So we are, as pharmacists, we're taught to counsel these patients and give them advice, and we are medication experts. But it's also important to ask the patient for permission before you give them that information. It empowers them and it really gives them freedom to choose. So instead of just going ahead into the counseling, ask them, would you like me to take a few minutes to go through this information about Perindopril with you? Or may I give you some helpful hints about managing your blood pressure? Very few times in practice have I actually had somebody say, no, I don't want to talk about this. And if that's the case, you can give them or ask them permission, well, can I give you some written information to take home? And then you're still sending them out the door with info, but you're still allowing them to choose. So asking them what they already know about the topic. If they already know about side effects and they tell you them and it's accurate, maybe you don't have to go through that. So affirm their knowledge. Ask them permission to fill in the blanks if you need to, and then give them the information or advice. Yeah, the writing reflex I want to touch on again because I think it is a natural tendency for us to jump in when we think we need to correct the patient. So if you ask a patient if they're interested in quitting smoking and they say no, and then I say, oh, well, you need to because if you don't, this is going to do this, this, and this, that might actually be creating more resistance to change. So in the instance of Perindopril, patient said, I don't want to take it. And instead of me accepting where they are, if you don't take Perindopril, it would really help bring your blood pressure down. I can give you more information about the medication. I'm probably creating more resistance at this point. So what you could do is get the patient to tell you more about why they don't want to take the medication. And do you think that your blood pressure is going to improve if nothing changes? So resist the urge to convince somebody they have a problem, argue for benefits of change, tell someone how to change, because I'm sure we've all experienced that and know how it feels, and warn them of consequences if they do not change. What you can do instead is guide the patient to talk about change and think about it, so explore their feelings about it. What are the benefits, the pros and cons? And the last one I will show you. Agenda setting is another tool you can use. So this is something I use with my hypertension patients. The bottom you can't see here, but there will be blank boxes for the patient to write in what they want to learn about as well. So these are all things that can affect hypertension, and I will ask them to rank them in order of importance to them, and also write down if they have other topics we want to cover. And then we'll start with the topic most important to that patient. So even though I really want to talk about medication, the patient is more concerned about smoking cessation. So we'll start there first. So if you are in a brief encounter with a patient, just to summarize, if you want to start trying out some motivational interviewing skills, you can start by establishing what the patient already knows about a topic. So ask them, what do you know about Perindopril? What have you been told? Then support their autonomy by setting the agenda, asking permission before you go into your counseling, and asking open-ended questions. So engage the patient in change talk and get them to talk about the reasons why they may or may not want to change and what the benefits are. And if applicable, you can get them to set some goals to work on before they see you next. In conclusion, behavior change is hard, but motivational interviewing has been shown to help people change behaviors by exploring their ambivalence toward it, and it has been successful in improving medication adherence. So pharmacy students might improve ACE or ARB adherence. through a telephone intervention. And I've given you some tips on how you might incorporate this into your practice, or at least reflect on your current approach to patients and whether this might be helpful. Hopefully this was helpful to you. If this is a topic that interests you, then please let me know in the evaluation I send out, and we can certainly schedule more sessions like this. But I will stop there and see if anybody has any questions for today. Okay, thanks so much, everyone. We'll see you back in a couple of weeks' time. For Grand Rounds this month, we have the Chief Privacy Officer, Kelly Chase, who will be speaking to us, so be sure to try and come out for that. And I hope you have a great rest of your day. I'll talk to you soon.